Hi everyone, welcome to 141st Stanford MedAI Group Exchange session. This week we have Kenza Benkirane from University College London uh, here to talk about her work on diagnosis and treatment of bias in large language models for clinical decision making. Kenza has a background in health data science and machine learning with experience across France, Germany, and the US. She studied biomedical engineering at INSA Lyon and artificial intelligence for biomedicine and healthcare at University College London. She previously worked in digital health consulting at EY, contributing to health data sharing initiatives with the French Ministry of Health and European Commissions. She's now working as an NLP engineer at a clinical research organization where she works on applying language models to clinical use cases. So, Kenza, thank you very much for joining us today. Before we start, do you have any preference on how you would like to take questions? Can we interrupt you in the middle, or do you have designated breaks in your talk for questions?
Thank you, Amara. Sure, you can interrupt me for questions.
Okay, thank you. Then, everyone, let's try to make this session as interactive as possible. And without further ado, let me hand it over to Kenza.
Thank you. So this research was held last summer with my two co-authors, Jackie Kay and Maria Perez Ortiz. Before I start deep diving into the research, I would like to make a small disclaimer that we could not, unfortunately, involve clinical professionals' advice to create this research. Even if we would have loved to, we do realize that it is important to keep involving healthcare professionals in AI research. So that was just a small disclaimer on all the research choices we've made along the way. So I will present you first the context, the research context we had back at that time in terms of data set, clinical decision-making evaluation, and LLM evaluations. And finally, I will present to you the methods we've used both for the data set and the debiasing experiments. So in terms of context, this was held, as I said, between June and August 2024. So back then, we had a very strong realization that LLM are perpetuating social biases and that current debiasing methods are not enough, both through evaluations of their outputs, but also of their embedding spaces. We do know that it's due to their training sets, which for most of them we don't have access to. In terms of evaluation of large language models and biases, we do know that there is a real need for relevant evaluation, and this was the case last summer, and this is the case today as well, that benchmarks are failing to really show how LLMs are performing in terms of clinical decision making, but also in terms of biases. And finally, most of these benchmarks were and are based on multiple choice questions, which is not enough to really assess the understanding of clinical complexities in clinical decision making. So these are all the reason why we decided to work on the JAMA Clinical Challenge dataset. So these are cases, clinical vignettes, where the healthcare professional found complexity in solving the question. This is a very rich data set, not only because it has, well, first a clinical vignette and an open clinical question and then four options, but also because it has an explanation associated with the correct option index. The explanation is very detailed and long and written by a healthcare professional. So we chose this data set because it had both a multiple choice question and answer, but also that explanation that is quite rich. It's also quite rich in terms of therapeutic areas. We have ophthalmology, dermatology, psychiatry, pediatrics with different distribution across therapeutic areas, of course. One big limitation from this data set is that it did have lots of images, for example, or other types of healthcare data, ECGs, for example, EEGs sometimes. We decided to work only on the text from the data set, so only the question and explanation, and not the other modalities, on purpose, because back then, well, VLMs were not powerful enough, and our evaluation is mostly on the bias, so a comparative bias across gender and ethnicities. I will come to it more precisely later. So it was a choice not to use these other modalities, even though we do acknowledge that it's a huge limitation. This was also based on this work from Chen and al. From February 2024, which was benchmarking LLMs on answering and explaining challenging medical questions. In this work, they evaluated a explained and answered and explain different types of predictions for different types of data set. And they did find that JAMA had way lower accuracies across the four LLMs evaluated than other benchmarks such as MedQA, which is one of the most popular data sets used on research. Also, when asked for explanation, it did see that it had better accuracies. Um, so this was the baseline information for our research. We really wanted to evaluate both the MCQ and the explanation for different types of patient populations. So from this study, we decided to create counterfactual patient variations. Before doing that, we first worked on assessing the data set, meaning we did a very long period of time was dedicated to data pre-processing and analysis. We didn't use LLMs for this step. We just used regular expressions and lots of human double checking at each step. So first, we filtered out cases where gender swapping wouldn't make sense, such as pregnancies, women's health issues, etc. Here, what's interesting to consider is that sometimes in the clinical vignette, they would mention that there wasn't hypothesis that the patient may be pregnant, but wasn't. So even in these types of cases where the clinical problem is not related to pregnancy or any woman health issue, we also filtered out these cases so that the data set will still make sense. Also, in some cases, the ethnicity of the original patient was mentioned in the clinical vignette. So here again, we decided to remove such cases so that it would make sense in terms of the original case would not have any ethnicity mentioned. And finally, it's not written here, but I'm just telling it here. We saw that a few dermatology cases had ethnicity mentioned or Fitzpatrick skin type mentioned. So we also decided to take out all cases from dermatology because here we realized that ethnicity may have a clinical impact. Again, this was made by non-clinical researchers. Also, thanks to regular expression in this first pre-processing step, we could identify the original gender of the clinical case and also the clinical question that was asked, which was 1 out of 4, which can be how do you interpret these test results or what is your diagnosis? A side note also from this data pre-processing step is that we considered 3 genders, female, male, and neutral. Most of the original neutral cases are babies under 5 weeks. So there, in most of the cases, the gender of the baby is not mentioned. So yeah, just a small data set bias. After doing this pre-processing step and having a filtered and processed database, we proceeded to the counterfactual patient variations, where for each clinical case, we created variations in terms of gender only and in terms of gender and ethnicity cross variations. This was important for us so that we could evaluate both how the multiple choice questions would change and also the explanation just by changing one token. Also, we made sure that the switch was natural, meaning that we didn't add a sentence in the beginning, such as lots of research papers do. We really injected a token or switched a token exactly where it was in the original clinical case so that it will follow the original writing of the case. After that, we first went through a exploratory bias evaluation, meaning that we just wanted to see as a first step how would the models behave with regards to these variations and evaluate the performance in terms of multiple choice questions and of explanation. Um, to Please interrupt me if there is any question. To go ahead with the evaluation of both the MCQ, as I mentioned, and the explanation, we used a few metrics. First, the accuracy difference across categories being, well, gender only, but also gender and ethnicity. I will go deeper into that later. Equality of odds. We also use this Q size, which is from Albuquerque and all. Evaluating model bias requires characterizing its mistakes. So this Q size quantifies distributional bias. So whether the errors differ across subgroups in a systemic way. So this is why we use this metric. And finally, we used SHAP value to evaluate the effect of the prompt on the accuracy. For the explanation, our study was based on this paper from Dolci and al. Improving gender-related fairness in sentence encoder, a semantic-based approach. So for the explanation, we mostly worked on the embeddings. We used mostly GPT-3 embeddings for GPT-3 outputs. GPT generally, not just the 3 model. Here, why is it interesting? The gender bias in the paper refers to the unintended association between gender neutral words or sentences and gender stereotypes encoded in sentence embeddings, meaning that there was a list of very strong gender connoted words, which allowed the writer of this paper to identify a gender direction, and this is how the gender bias is evaluated. And for the bias score, it's estimating the amount of stereotypical gender information in the embedding by weighting the gender bias of each word based on its semantic importance. So this is what you can see on the left-hand side here. So after evaluating after this first experiment where we just compared how the model was behaving with this token switch, we went forward with debiasing attempts, first through prompt engineering and secondly through fine-tuning.
Kenza, I think we have a question from the audience. Multiple choice, what type of answers are given as alternatives?
I'm not sure I understand the question, but I'm gonna
Uh,
just
Ramon, do you want to go ahead and ask your question yourself?
Oh yeah, sorry, I missed this portion. Because my question was if let's say it's primary syphilis. I just wanted to know how close to if the other options were like completely wrong answers or slightly possible. But yeah, I just missed this portion here. Yeah.
Yes, of course. Well, I cannot comment on that, obviously, I'm not a doctor, but it is a complex clinical data set, so it's not supposed to be from
I
what
think we
I'm.
have other questions from the audience too. Amin, do you want to go ahead and ask?
This is the opportunity, then I will ask immediately. Just a question was regarding to those clinical cases that had images included. Sorry, I didn't introduce myself. I'm a clinical scientist from and clinician from hematology. Um, so my question was for those case vignettes that had images such as ECGs or something else, did you still use those cases or did you eliminate those questions entirely? Or did you just keep the textual content without the images? It's a detail, but just a short question.
No, I understand it is important because what was important for us here was to evaluate the bias, so the comparative performance, not only whether it was correct. And yeah, I think that's
Did you
it.
compare those in subgroups? But maybe you will show it later. It's just interesting because it's a different kind of information that is then missing in that context.
We did not compare, so we have the information in the data set, but we did not compare because the problematic is that it would have been interesting to know what information is missing in the case that you would have found in the other modality and how relevant that information is. So the only information we had was, is there another modality in the case? Yes or to be quite honest, we didn't use that information because even the text only gave us quite a lot of evaluation to do. And also, well, the most relevant thing to do would have been to have a doctor evaluating the relevance of this extra information and extra modalities. So no, unfortunately, we couldn't do that.
Thank you for your comprehensive answer.
Sure. I think it was here. Yes, so in terms of experiments, after the first evaluation across the different counterfactual patient variations, we tried two methods for debiasing. The first one using prompt engineering, and the second one using fine-tuning. So for prompt engineering, we used this paper from Entropic back from February 2023, which is the capacity for moral self-correction in large language models. In this paper, they propose two ways of debiasing through instruction following and chain of thought. So what I showed in yellow here is what I added in the prompt for this specific experiment. So the prompt already had user prompt and system prompt and chain of thought for clinical case evaluation, but we did add specific bias-related questions from this paper for the debiasing experiment. And in terms of fine-tuning, we did find it a little bit tricky because we had these two tasks, so multiple choice question answering and explanation. So what we did is that we decided to fine-tune two models separately. So here are the details on training examples, epochs, batch size should be 32. That's a mistake. And learning rate multiplier. So why did we use two different models is that we realized it's two very different tasks, and we needed a way smaller data set for the multiple choice questions because more training example led to overfitting. And for the explanation, the task is quite complex because we wanted the LLM to output a high-level explanation, just as in the JAMA dataset, which prompted us to use more training sets there. So all these training hyperparameters were iterated multiple times. We fine-tuned GPT-4o Mini. Well, another very important detail is that we use the OpenAI platform for fine-tuning because we wanted a black box perspective. If we had more time, it would have been great to have a open source model as well and really evaluate weights and the effect of the fine-tuning on the debiasing. But unfortunately, that's what we could do with the very small time we had. And also there was what we wanted to do is also we knew that most healthcare professionals will not go ahead and use open source models, and that nowadays GPT is, well, one of the most popular models used in the industry. So we wanted to use GPT, and also we wanted to see how a black box evaluation could work. Also, in terms of fine-tuning strategy, we decided to prioritize older clinical cases. We highly doubt that this data set was used for training of GPT models, but we do not know for sure. So our strategy was to use older cases for training, and then more recent for validation, and then more recent again for test. So in terms of results, we had quite interesting findings. One of the first one is that we do have different results just by changing one or multiple tokens from the exploratory counterfactual
Kenza,
patient.
can I ask you one quick thing? Because I'm a little bit confused here because as you mentioned, I completely agree with you that we'll never be able to drop out that possibility that this dataset also has been used in the model training, right? Or since you are using kind of like a black box model. So did you evaluated also the performance before your fine tuning?
Yes, of course.
Is it in the table or?
Yes, so the table shows the results for 3 experiments before fine-tuning, before any debiasing evaluation, and then the results after debiasing with prompt engineering, and then the results after debiasing with fine-tuning.
So which one is your basic result? Because you mentioned GPT-3, GPT 4.0, and GPT-4 Turbo. I'm missing like which one is your best results without any fine tuning?
So here I'm showing the results of the first experiment, which
Okay.
was evaluating the swab. But later, I think, yes, it's here. We have the baseline and the fine-tuned models that are compared, but this is for later.
Okay,
Now,
I was thinking you would be fine. You would be showing the experiments with GPT-3 with and without fine tuning, GPT-4 or
no,
without fine. Okay.
no, because I didn't fine-tune all the models, and I'm
Mm.
just showing the results experiment by experiment. And also, I will explain it later, but the comparativity is a bit subtle, but I will explain later.
Okay, no worries. Thank you.
So first, these are the results of the exploratory counterfactual patient variations, meaning that we're just comparing for the same clinical case how it behaves when swapping the gender or adding the ethnicity. This is without any debiasing evaluation. So for the first experiment, we showed that introducing ethnicity did lead to changes even in gender-related disparities, changes that we could not necessarily see in the gender-only variations, as you can see here. The numbers are very low indeed, but it is a comparative study, so we thought it was quite interesting here. Also, we did see that the differences were not the same across ethnicities. So for this first evaluation, we only had 3 ethnicities, Asian, Black, and White, but for the ones after, we did add a few other variations. And then in terms of SHAP features, we did see that surprisingly, some tokens were more present related to some tokens related to social biases were more present. We did see, aside from bias, a negative importance related to optical cases. But here we can also see that for some models, having the token man or Black or Asian can change its its performance on the multiple choice question. This relates to these previous results, but this gives a more deep dive on the results.
Kenza, I have a question here. This is a comparison in the accuracies, right? So if you introduce female versus neutral, the accuracy improves, or um, is like any kind of change in performance, I would assume that indicates a bias, right? So do you interpret it differently if the accuracy improves or if the accuracy decreases by introduction of a gender or ethnicity token? Do you have like a do you think we should understand it or like increase or decrease? In any case, there's just bias, or do you think there's like a different notion uh, to the experiment's results if the accuracy is improving versus the accuracy is decreasing?
So the way we define this is that for one clinical case, one particular patient, the result from the LLM should be the same whether whichever gender or ethnicity,
Mm-hmm.
meaning that having a better result or a worse result, both are biases.
Okay.
Yes.
Okay. Thank you for clarifying.
Um, in terms of fine-tuning, here I will go ahead with the subtlety I just mentioned from the question. We compared GPT-4o Mini, the baseline model, and the fine-tuned model. What is here is the results. The subtlety is that if you remember, the fine-tuning was task-specific, meaning that we fine-tuned for multiple choice question a specific model and for explanation a specific model, meaning that here these results are not from the same prompt exactly. For the multiple choice question model only, we didn't ask for explanation because it was fine-tuned for MCQ. And for the explanation, we gave the choice and asked for the explanation. So we did compare the two models, but because of the fine-tuning strategy, it's not, well, it is a subtle comparison, but it is the same model with and after, before and after fine-tuning for task-specific questions. And what we did see is that we had good gender bias mitigation, meaning that here before for the baseline model, female and male had well around 1.5% difference, and after it's one difference, and the neutral case was the case with the best performance. And what we do see after fine-tuning is that for ethnicity, some ethnicities had a way bigger performance boost, for example, Arab or Asian compared to the baseline model. We do not know exactly how to interpret these results, but one hypothesis is that these ethnicities are maybe less present in training sets, and introducing them in our fine-tuning data set may have changed the importance of the token. Also, a very important information that I didn't give in the fine-tuning explanation. We didn't just fine-tune on clinical cases. We fine-tuned giving the models multiple times the same clinical case with different genders and different ethnicities. So we put each clinical case 3 times with the 3 genders and 3 randomly picked ethnicities, such as across the whole data set, the distribution is homogeneous across ethnicities, but for one clinical case, we had 3 out of 5 ethnicities. And this is quite important because the strategies that we would teach the model to unlearn the importance of the gender and of the ethnicities by giving it the same clinical case 3 times with variations and the same results. So the same MCQ answer and the same explanation, the explanation being adapted to the gender, obviously. So yeah, we believe that was important here, but as we can see, it did not show the same results across all the ethnicities. One other very interesting finding is that for the explanation, the bias score did lower quite importantly for the embeddings. As we can see here, it's the baseline and here the fine-tuned model. We can see that the bias score and the gender bias score as well were more neutral than they were before fine-tuning.
Kenza, just an explanatory question, if you can move back. So this bias score, it's for the embedding of the token,
Yes,
right?
exactly.
So what we see is that the token embedding is less biased in the fine-tuned model than it was in the baseline model. But when you move on to the question answering part, it's probably not having the desired effect.
Yes, exactly. So we saw that for the question answering, the performances were way more distributed across ethnicities and a little bit across gender, but the explanation did show that the explanation bias score did get more neutral. So these are two very different metrics and different evaluation. This that in terms of performance, it's more well, heterogeneous, but here we could see some kind of agreement in the explanations, embeddings.
Okay, thank you.
Sure. And then I will present the prompt engineering results. These were a very big heterogeneous results. Here we can see that for some models, chain of thought and instruction following did work for performances, especially GPT-4 and Gemini 3. Gemini 3 had one-of-a-kind results. These were not comparable to any other model, but one trend that we saw is that bigger models were behaving way better with chain of thought, which is a result already realized in research. But prompt engineering was not a robust debiasing method, definitely, because the results were quite different across models and across evaluations. And one final very interesting result is the variability of embeddings. When we looked a little bit deeper at the data, we saw that for the baseline and fine-tuned models, the bias score would be either masculine or feminine leaning depending on the medical specialty. So this means that, for example, for ophthalmology or diagnostic, we saw that the embedding had a very strong feminine bias score, while for oncology and cardiology, it had a very strong masculine bias score. And actually, the fine-tuning exaggerated these traits for most of the specialties, for example, from diagnostic to cardiology, especially for neurology, but and did not compensate these biases. So this means that the embedding spaces that we use, which are from GPT, it's text embedding large, so the latest and biggest embedding space back then, are not adapted to a medical specific evaluation, and that maybe we need more strong and more specific embedding spaces to evaluate explanation of large language models for clinical decision making. So in terms of conclusions, we did see that there is some strong biases, both for the multiple choice question and the explanation. Another very interesting finding is that sometimes the multiple choice question will be correct, but the explanation would have flaws. So this is something we saw quite qualitatively, and again, we would need healthcare professionals' assistance to really assess on such discrepancies, especially at the bigger scale. Biases are not limited to final answers. The explanation also reveals significant disparities. This also relates to the first context that I presented earlier, that we have a lot of benchmarks, but how do we actually evaluate LLM's outputs at a big scale? We did use embedding spaces, and we did use two very interesting metric for gender, but we didn't have any metric for the ethnicity explanation. We could do a few word cloud, but this remains qualitative and not enough for robust evaluation of explanations, especially from a clinical perspective. We did realize that prompt engineering is not sufficient, at least in the framework presented with instruction following and chain of thought, and that maybe prompt engineering for clinical decision making must be, well, more task specific. There are lots of flavors possible, either by medical specialty or by model size, but there is not one size fits all prompt engineering method, obviously. We did see that bias varies across medical specialties, as we just saw. And that explanation-based evaluation is key, and correct answers can still be based on biased reasoning. Another interesting information that was published after we wrote this paper is that we've seen that LLMs tend to give explanations that we want to hear, not more related to what the humans want to hear than what really was the reasoning that they had to create their outputs. So, well, the explanations are also not enough in a clinical decision-making framework. In education, this can be very interesting for, well, healthcare professionals' education, but for explaining the LLM's answer and for more transparency for the patients, well, right now, from my understanding, that is not yet enough. So the biggest takeaway is that we need to reduce bias, but it needs more tailored and multi-level and multi-dimensional evaluation of biases. Thank you very much, and please, happy to take questions.
Thank you very much, Kenza. So before we move on to questions, I'd like the audience to give our speaker a virtual round of applause for this very informative talk. And now the floor is open for questions if you have any. If not, maybe I can start with one. So, Kenza, this was interesting that there is a feminine or a masculine bias in like certain. Do you see any experiments to explore that further? Do you think like that leads to a situation where different kind of debiasing would be needed for different medical specialties? Or do you think no matter what kind of bias we are looking at, whether it's feminine or masculine or improving the accuracy or decreasing the accuracy, basically the debiasing techniques would remain the same?
I think that this does show that there is a gender association between a specialty and a gender. And actually, this was also shown in another paper from, I think it was from a French university that tried to generate cases with GPT. And they've seen that for cardiology, it would majoritarily generate male cases, for example. So in terms of experiment, I think there's lots of evaluations to do. Here, the paper I just mentioned is about generating cases. What I've done here is evaluating the embeddings. I think that what we're seeing in the medical LLM landscape is that we have more targeted models specifically for medical use, and I think, from my humble opinion, that it's a good direction, but this does need to take into consideration, well, this and also embedding evaluation. I'm thinking of that because the embedding space, vocabulary, and precision in such specific medical specialty may be a very big win, I think, for both clinical quality of explanations, but also for embedding spaces.
Okay. Okay. Thank you very much. If somebody has any question, please feel free to go ahead.
Hey, Kenza, I have another follow-up question about that. Since you particularly mention all these like matrices that are calculated from the embedding space, but don't you think like embedding space evaluation is one aspect, but finally the goal is to evaluate the model output actually after you do the decoding? Because there
Yes,
can Mhm.
sorry.
Yeah, there can also be like bias or like anything introduced at the decoding step.
Yes, I do agree. It's just that, well, the model understands embeddings, so it's going to translate any input into its own embeddings. And here, especially for this case, for this slide here, it's GPT embeddings with GPT models. So if the model's embeddings are not precise enough, how can
But
we?
so imagine like you see the bias score here, right? Like the bias score does not always means that the model is like embedding is not precise. It seems like it is kind of like leaning towards either if you are evaluating gender-wise bias, either leaning towards the gender, leaning towards one gender. For example, if you are taking the example of cardiology, I agree that of course we have more male cardiology patients, so the model embedding could be leaning towards the male population. That does not always means that the model embeddings are imprecise, don't you think? It just I want to understand your opinion.
Yes, I understand. I'm just wondering that in the case that there is a female cardiology patient or a
Hmm.
male ophthalmology patient, my belief is that the model should give the same quality, whatever the gender. So if the model treats that case as an exception and doesn't, well, take into consideration everything that should be taken for the specific gender, then there is a bias. So my belief is that if we have embeddings that are more strong and training set that are more strong and robust towards the specific specialities, then it would be better in terms of quality of output and explanations. But that's
But
just
also
a
in the cardiology case, for example, we know that the female has less chance of developing any cardiovascular event than male. Like it is a truth, right? Like it has been evaluated multiple times that female has less chance of developing cardiovascular event, particularly during their like at least the age of 45, right? So particularly when you want to analyze that case, you want to capture that bias that yeah, female has less tendency of developing cardiovascular event than male. Like they are not the same group or they don't have the same outcome.
yes, I understand that. That's why I'm thinking, should the LLM treat the woman, if there's a woman? I mean, I understand there are way less, but there still are.
But they should
Um,
be treated differently, right? Because the woman developing a cardiovascular event during the age, like younger age, is kind of a rare event.
yes, probably.
Do you guys think there is another dimension to bias? Just like adding on to this discussion, if the idea is that younger female is just less likely to develop a cardiology event, do you think that it is worth exploring, evaluating bias in basically like across like two, three dimensions? Like look at the gender plus the age,
Yeah,
maybe plus the ethnicity.
that's yeah, right, Tamara. You got the point, right? Like that is my motivation that I think that this kind of like particularly when you analyze a bias in the embedding domain, they are not a single factor bias. They are always a multi-factor bias.
Mm,
so analyzing in a single, only based on only single factor is kind of, I don't know, incomplete. Yeah.
Yeah, which would probably lead us into a discussion of like what's a complete set then. We can try and increase the dimensions, but we don't really know like how many factors we should evaluate for.
Right.
Like, is it gender plus age plus race, or is it something else as well? Like, should we include BMI or should we include social determinants of health?
Right.
But that's an interesting evaluation, like if somebody can manage that. Kenza, please add if you have any thoughts. We don't want to hijack the discussion.
No, I completely agree. This is one of the limitations we mentioned in the study. Social determinants of health are one of the major determinants, obviously, of biases in healthcare and in not only diagnosis but also treatment. Here it is an incomplete study, and what I may add is that we did see huge differences between changing the gender only and changing the gender and adding the ethnicity. So this multi-dimensionality that you're mentioning is definitely important to take into consideration at the same time. Yeah.
Yeah, that's a good point.
Yeah. Thank you very much, Kenza. If nobody has any further questions, then let's give our speaker another round of applause. And if you have any questions later, hopefully we can get you in touch with the speaker. And thank you very much, Kenza, for this very informative talk. Thank you.